So if you look at the previous available testing, we had ocular computed tomography, stereophotography, visual fields, pachymetry, intraocular pressure. Those are the 5 basics of glaucoma assessment. Corneal hysteresis has a completely different component that it adds to that process. Those are all data-based and quantitative, but corneal hysteresis allows the clinician to have a view to the future. I would analogize it as the A1C hemoglobin of glaucoma, because in diagnostic settings in diabetes, we use A1C to see the global effect of diabetes on the system, and doctors use that as a predictive value. That's how I tell my patients that we're going to use this information. This is just like your testing in diabetes to tell me how well you're performing and what your risk is going forward, as well as your current risk for disease diagnosis. And patients actually really appreciate the fact that we have something that is that substantive, because previously it was all about intraocular pressure and sort of quantified systems. This gives me an additional element that's very powerful. Corneal hysteresis is a key element in the decision-making process. There are hundreds of papers that identify hysteresis as the mechanism or component that allows me to predict future behavior, both in degradation of visual field, loss of retinal nerve fiber layer, correlation to glaucoma, pressure levels relative to progression. Each of those elements gives me or my colleagues the capacity to add a layer of competence to our diagnostic assessment, and I use it to understand who needs to be seen more often, how I want to change my goal pressures in the management process, and eventually how I'm going to look at that patient long term, whether it's either medical or surgical intervention. On the glaucoma suspect side, patients who are potentially drifting or moving towards glaucoma, it gives me a window of opportunity to understand future behavior. And patients who are glaucoma suspects with lower hysteresis are going to be watched more frequently. It may have been I've seen them once a year in the past, now I might see them twice, or maybe even 3 times a year, understanding that their risk rate is that high. Within the device's capability, beyond corneal hysteresis, is additional testing elements that are delivered. IOPCC is certainly the most relevant of those elements because it matches the patient's Goldmann readings in the normal population at an extremely high level. It's literally almost a template on top of a template level of reproducibility. But the beauty of IOPCC is that in the glaucoma population, it varies from Goldmann measurements, and it actually becomes the true pressure of the patient, because in those individuals, corneal thickness and other factors change the Goldmann measurement inaccurately, whereas the corneal IOPCC is a derived measurement that can be relied on over time to measure the true intraocular pressure. So corneal hysteresis is measured by an instrument called the Aura G3. It's by Reichert, and it has become an integral part of the practice. The beauty of the instrumentation is that it's a relatively small footprint. It's very simple to place into the intake aspect of the patient's encounter in the practice, so that by the time I see the patient, that test has been delivered to the medical record or to the EHR, and it's available for me to review. The other factor, which I thought was very pleasant about the device, was that it is simple to learn, simple to use, and within an hour, my technicians, which are really a group of great people, easily took on the technology and now made it part of their day-to-day activity. Unlike much more expensive instruments, OCTs and some of the other high-tech diagnostic systems for optic nerve assessment, this device sits in a standalone capacity and literally can be used on every patient, even if they don't have glaucoma, because it's a way to measure intraocular pressure at even annual visits. Aura, or the Ocular Response Analyzer, was approved originally by the FDA in 2004. It's been through several iterations and is now in its 3rd generation as an instrument. During that time period, it additionally was approved by FDA for a billable code, which is the corneal hysteresis code. That was in 2014. That code is the most recent and actually probably in the last decade, the only code that's been approved that's new in the glaucoma field. So the literature that was presented for the FDA approval for reimbursement was so strong that the instrument actually achieved that in a very short period of time and is now available for clinicians to use in their practice, both as a clinical tool, but also as a mechanism for income generation relative to the other diagnostic systems in glaucoma. Aura, which is the instrument that allows us to measure corneal hysteresis, is not only the newest of the technologies approved and available for implementation, but it's also sort of the perfect fit for the other technologies. There are flaws in every diagnostic system, whether it's OCT, visual fields. They all have great opportunity to give information, but they also risk overinterpretation. This device gives me the ability to look at those elements and add a level of depth or finish to the diagnostic process that I've not had before. And I think that's really where it fits the best. It gives me the assurance that these 6 tests that may be borderline now show a very positive CH, and I'm going to treat that patient. Conversely, if that patient comes in and things are borderline, but the CH is high, I'll monitor that patient. In the past, that dilemma was much more difficult to solve. This has sort of opened the door and given me the key to the other side.